So when I first made the switch from the clinic to the hospital, I had some advantages. Having a couple years of medicine underneath my belt, that obviously was an advantage, because as far as developing the differentials and the workups behind certain things, I kind of already had an idea about a lot of that stuff. So having a few years of primary care before you transition to the hospital is never a bad thing. Not only that, it gives a lot of advantages, and I wouldn't go so far as to say that it should be required, but it would be ideal as far as the training goes. So what would be like an excellent way to onboard someone for the hospital would be to make them work in clinic for a couple years so they knew exactly what could be done in clinic and what can be managed as an outpatient. There's actually a lot of stuff that can be managed as an outpatient. The public doesn't seem to think so. A lot of times the public seems to feel like everybody is safer and the care is going to be somehow better if you're in the hospital, whereas that's only partially true for some of the more acute conditions. A few years in clinic will teach you what exactly you are capable of managing in the clinic, which is actually quite a lot. I was also pretty worried before I transitioned. I knew that the patients were sicker, and I'm an EMT now, and so I've participated in lots and lots of codes, but I'm typically not the one who runs the code. So I knew that sometimes patients would be in acute distress, and sometimes their heart would stop, and I was really worried that I would have to get really good at running codes. Thankfully, at my hospital, there's a rapid response and code team with an intensivist, a resource nurse, respiratory, there's a team that gets dispatched. Obviously, if a rapid gets called on your patient and you're there, since you know what's going on, you should respond immediately. But when it comes to actually running the code, they have people who it's more their specialty. I was really happy when I learned that for the floors, my patients aren't dying left and right. It's not ICU. So I was really worried that I'd have to take care of patients in that really acute, rapid code blue capacity, but I don't really have to do that often. Thankfully, I have an ICU team to reach out to if that's needed or if my patient decompensates. So that's nice. Some things that were really difficult to get used to were having to manage every single aspect of the patient's life while they're there. It actually took me a little bit of time before I was comfortable programming things like, are they allowed to get out of bed? What is their diet? Is there a daily fluid limitation? Like, these are things I never had to think about, and it took a while for me to get used to managing every single aspect of a patient's life. But I think the biggest thing that kind of shocked me in doing this job is how much not medicine there is. There's so much that we have to manage that doesn't have anything to do with the diagnosis or the medical treatment. Social stuff like, does this patient live alone? Are they safe when they go home? Are they able to get up and walk and go up and down stairs? When I was in the clinic, I never sent anyone to a nursing facility. What are the criteria for sending someone to a nursing facility? There's so much that we have to think about that has nothing to do with medical training or medicines or surgery. We call that social stuff. So a huge part of this job is what I like to call the verbal chess match. Being able to communicate with various members, not only of the medical staff, but also of the patient's family. That's a skill just like any surgical skill. It's verbal skill. It's mental and it's an emotional skill as well. If you're pretty good at talking to people and reading people, it shouldn't be too hard. So not only do you have to kind of know your medicine, but you've also got to develop your verbal and emotional chess skills. Sometimes I only have a little bit of information and I need to go into a room and, there's Nana on the bed, there's 4 children over there and 3 grandchildren over there, and they're all looking at you when you come in, and you have to very quickly identify who's hostile, who's on your side, who wants to listen to you, who doesn't want to listen to you and they just want to tell you what they have to say, who is scared and venting, who is actually just curious. You have to get a make on everybody very quickly. And sometimes you have to tell different people different things to get them on your side, to demonstrate that you have a direction for Nana's care. So that kind of skill is not something that they teach you in school. I think if you come from any job where you've had to deal with the public or communicate with people in high-stakes situations, you'll excel at it. But just know that is a soft skill that is critical, and it can make the difference between how much you enjoy the job, how you're perceived at the job. How you carry yourself and how you present yourself are critical here. But the way you carry and present yourself has a lot to do with the amount of homework you've done prior to seeing the patient and how well you know their case, which I'll talk about in a future video. So the actual transition itself presented a whole new batch of challenges that I didn't quite anticipate. But the skills that I've developed, they serve me in all aspects of life. Life is about people, and being able to communicate with people effectively, listen to people, read people, not just what they're saying, but what they're saying non-verbally, the subtext underneath the spoken words. It's a great skill to have and develop. In the next video, I'm going to talk about how the job is day to day, more aspects about that. So until then, I'll do what Jefferson Fisher does. I'll say, try that and follow me.